is good. Okay, I don't know if I'll be able to pull up my PowerPoint, but we'll get started, and if need be, I can always pull it up later if I can do that. Okay, so the first important thing with this is to basically recognize the difference between melanin pigment and hemosiderin pigment. So the melanin pigment is going to be much more coarser, darker, black brown as compared to hemosiderin, which is going to be more of golden brown and refractile. Honestly, it's much easier to recognize the difference between these two pigments when you are visualizing the slides under the microscope. But in digitalized slides, it's a little challenging. So what you should look is for the color. So more goldenish color is going to be of hemosiderin, whereas this coarser, darker, blackish brown is going to be melanin pigment. Melanin pigment also is not refractile, so it's not very shiny, whereas hemosiderin will be. Now, why are we talking about that? Because when you see melanin pigment, you obviously are thinking about either melanocytic tumors or inflammatory dermatosis, which have resolved with post-inflammatory changes. So its recognition is extremely important because it can lead you to different pathways. For hemosiderin, you're most commonly seeing trauma, scar, foreign body, Monsell's reaction, prior procedure. So, dermatofibroma versus a blue nevus. So, and we'll discuss all those scenarios. So this is a melanin pigment within a very heavily pigmented blue nevus. Okay, so one of the first things that they like to test you on is testing the ability to recognize between post-inflammatory hyperpigmentation and melasma. So PIH is not really going to be a both slide because it's really like an invisible dermatosis. The only thing you see is pigment dropout in the superficial dermis, but then there is no cause for it. So the epidermis is minimally affected. There is sparse inflammation. You don't see macular amyloid. So nothing to explain the pigment dropout. That's post-inflammatory hyperpigmentation. This is going to be in contrast to your melasma. So the melasma that you guys most commonly deal with is the epidermal melasma, wherein you get epidermal hyperpigmentation with no melanocytic proliferation. So there are two kinds of melasma. The most common one is the epidermal melasma, wherein you can see that there is epidermal hyperpigmentation, no melanocytic proliferation. They may be slightly enlarged and activated melanocytes, but there is no melanocytic neoplasm and there is no pigment dropout. There is another kind of melasma which is referred to as dermal melasma, in which you do see the pigment dropout, but that is going to be if they're asking you the difference between melasma and PIH, they're going to show you the epidermal kind of melasma, which is the most common type of melasma. So that is melasma. Okay, coming again to your blue nevus. So blue nevus is, going to be proliferation of spindle dendritic melanocytes in the dermis, which contain melanin pigment. So recognition of, again, melanin pigment is extremely important. Now, suppose if you see something that looks like a blue nevus, but you do not have blue nevus as one of your multiple choice answers, then you can be dealing with dermal melanocytic hamartomas like Mongolian spot, nevus of Ota, and nevus of Ito. So those entities look exactly like a blue nevus and stain exactly like a blue nevus, except that obviously their clinical presentation is different. So so remember that. So the difference between nevus of Ota, nevus of Ito, and the Mongolian spot is that in nevus of Ota and nevus of Ito, the dendritic blue nevus melanocytes, they are basically present in the superficial dermis, like what you typically see in a blue nevus. It's more sparse and not a very well-formed lesion as compared to your classic blue nevus. So you can see here the dendritic melanocytes with the melanin pigment. In a Mongolian spot, you would see the same dendritic melanocytes, but they're going to be in the deep dermis. So you will see them in the deep dermis or, upper subcutaneous. So that's the difference between Mongolian spot and nevus of Ota and nevus of Ito. But they all are blue nevus-like melanocytes in the dermis. They will exactly stain like that as well. So this is a Soxton immunostain. And you can see that these are being highlighted with this stain. So that's in a patient with nevus of Ito. Okay. So one of the things that they want to test you on is a sclerotic blue nevus and its difference from a dermatofibroma. So a sclerotic blue nevus is on a low power dermatofibroma and a sclerotic blue nevus. they're essentially both going to look the same. So you will see that these lesions will have epidermal induction. So on low power, a blue nevus sclerotic variant can look very much like a DF. But the difference is, again, recognizing the presence of melanin or hemosiderin. The cells can also be misleading. So these are all blue nevus cells. They have a more spindle morphology, but the fibrohistiocytic cells of a DF can also look like that. So that is why recognition of pigment becomes very important. So you can see this is the coarser, darker brown pigment. You can see that it's present in the cytoplasm of some of these dendritic melanocytes. When you see a cell like this, that's very much suggestive of a blue nevus. So this is a sclerotic blue nevus in contrast to a DF, which will have more of hemosiderin. And I'll show you examples of that as well. Okay, now coming to some lesions which are, which one may think or be tempted to think that these are melanocytic lesions, but they aren't. And the two important ones are Becker's nevus and a Café-Alais macule. So the Becker's nevus, so the Becker's nevus is going to be Becker's nevus and Café-Alais. They don't have any melanocytic proliferation. They both look like lentigos. So you have to, understand the context in which they're asking you the question. So in a Becker's nevus, you get these elongated reedy ridges, which have epidermal hyperpigmentation in a lentigo-like pattern. So you can see this elongated reedy ridges in a lentigo-like pattern with epidermal basilar hyperpigmentation, but there is no melanocytic proliferation. Becker's nevus is obviously an organoid hamartoma in which you get aborted smooth muscle bundles. That's why you get hypertrichosis. So you can see these erecta pili smooth muscle bundles, but no melanocytic proliferation. Café-Alais macule, and that's why I wanted to share the PowerPoint with you, which I can't pull up right now. But if you Google a Café-Alais macule and you see it, it also looks like a lentigo. It also produces these elongated reedy ridges with basilar epidermal hyperpigmentation. But in a Café-Alais macule, you actually see coarse melanin granules within the melanocytes. So put up Café-Alais coarse melanin granules and you will see a picture. So there are large prominent melanin granules within the melanocyte. So that is indicative of a Café-Alais macule, but the background looks like a lentigo. And obviously, Café-Alais, you see it in syndromic conditions like Lepers, McCune-Albright, and neurofibromatosis. So you should know about that. Okay, so now let's come to your next pigment, which is your hemosiderin pigment. So hemosiderin, in contrast to melanin, you will see is much more golden brown. Does everybody appreciate the difference? And it is refractile. So it's much more golden and it looks more shiny. That's hemosiderin pigment. So this hemosiderin pigment is indicative of old blood or a trauma or a prior procedure, or if the patient, you've used Monsel's solution during the procedure. This is nice coarse hemosiderin. This is indicative of a scar, which probably was biopsied before, and it has got this hemosiderin within it. Monsel's granuloma is a really important board question. Monsel's granuloma, because it produces activated epithelioid histiocytes, can look really scary. So quite often when they show you a Monsel's granuloma, they will put obviously a malignancy in there, especially like a melanoma or a carcinoma. And honestly, the cells, the more longer you look at it, on higher power, you'll get scared. So you can see that all of these are very activated epithelioid histiocytes. Some of them are multinucleated cells as well with prominent nucleoli. But look at it in the entire context. So you can see that there is clearly a scar of previous procedure. There's effacement of the reedy ridge pattern, and the entire lesion is localized to that area. And this can really fool a lot of people. So, when dermatopathologists, young dermatopathologists, start their career, this is a common question that they will ask, like, am I missing something? So beware of that. So this can lead you down the wrong path if you look at it a lot. The clue is obviously going to be the pigment. So the pigment, the Monsel's pigment doesn't look really bright orange brown, golden brown, like what I showed you, but it is on the darker side. And you can see this pigment, which is present within the histiocytic cells. And there's areas of hemorrhage, there will be background scar. So this is a Monsel's granuloma, which is a great mimicker of malignancy. And hence it's a very commonly asked board question. So you should recognize this. Similar kind of a pigment can also be produce similar kind of a reaction, but a different color of the pigment is also produced by Drysol, so the aluminum granuloma. So we will talk about that. But this is Mons cells, and this is the more darker brown pigment. Okay, now let's talk about the DF. And I have showed you multiple times, a slide of a hemosiderotic DF. So dermatofibromas, the bigger they get, they can often get hemorrhagic and show hemosiderin within the histiocytic giant cells. The bigger the lesion is, the more hemorrhage it is, the more inflammation it is, the more hemosiderin it is, the more likely it is going to be benign. So remember that DFSPs are very monomorphic tumors. They do not typically have hemorrhage or hemosiderin or other inflammatory cells. So this is an easy DF to recognize because you can see the nice induction, the collagen trapping, and you see the hemorrhage. The more challenging one is like an aneurysmal dermatofibroma. So the aneurysmal dermatofibroma or fibrous histiocytoma, aneurysmal fibrohistiocytoma, or AFH is what it is called. It most commonly occurs in the head and neck region and is a very common clinical mimicker of melanocytic tumor or even a carcinoma. And what you see is that the tumor comes off in a piecemeal fashion. It typically lacks the overlying skin, and it is very cellular proliferation of these spindle cells. You may even see some scattered mitosis, but it lacks the atypia. But the clue is the abundant hemorrhage and the hemosiderin. So you can see that there is lots of blood and there is lots of hemosiderin. So this is benign. This is aneurysmal fibrous histiocytoma. Now, beware of another very similar looking terminology, which is an angiomatoid fibrous histiocytoma. So they often throw that in the mix to confuse you guys. So angiomatoid fibrous histiocytoma is almost always a wrong question. It's not going to be asked at your level. That's actually a true sarcoma. It's an intermediate level sarcoma, which has a specific genetic mutation, which occurs most commonly in kids. They share the same name, very close together, aneurysmal versus angiomatoid, but it looks completely different. So this is an aneurysmal fibrous histiocytoma or an aneurysmal variant of a dermatofibroma. So lots of blood and hemosiderin is going to be the clue. Okay. The next one, so now that we have talked about iron, I have to talk about foreign body reactions which contain iron material, iron or iron-like material. So these are actually pretty common. We encounter them quite a bit, and clinically they always get sampled because you are concerned about a melanocytic lesion, and this is not what you're thinking that you are going to get as the biopsy findings. It's very easy to ignore because the pieces of tissue are often shredded. So you may think that this is just an artifact, but this is true. And what you see is in the shredded pieces of tissue, you not only see lots of hemosiderin, old blood, but you also see this foreign material, which has this crystalline nature, and it contains this golden brown material. So you can see that. So this is a foreign body reaction from a metallic substance that contains iron. And this is really pathogenic to this lesion. So the key is to recognize this material. So you can see this golden brown material. This is all a polarizable foreign body, which it may or may not be polarizable, but it will have this very shiny golden brown consistency consistent with iron. This is a foreign body reaction. And believe me, this is not an frequently encountered foreign body reaction. It definitely, we see this, I wouldn't say quite a lot, but we definitely see it at least like once every 3 to 4 months. So this is a foreign body reaction from iron, crystalline iron. Talking about other exogenous depositions. So we have carbon tattoo. Carbon tattoo is going to be varying degrees of immunogenic response. So this is the one which is just deposition of coarse black material, which is deposited on the connective tissue around the vessels and on the fibers, but it doesn't incite much response. So it's just jet black material. So it looks exogenous. So that is carbon tattoo. Tattoo most often will incite an inflammatory response, and that could be eczymatoid reaction. So like contact dermatitis occurring within the tattoo. So you can see here the spongiosis with some, the lots of tattoo pigment in the dermis. So this has incited an eczymatoid reaction. Obviously, the one that they really like to ask you, I don't know if it is a more common one or not, but they definitely like to ask you is the sarcoidal granulomatous foreign body reaction. So you can see this sarcoidal granuloma, these well-formed granulomas with histiocytes and giant cells. And you can see this kind of the pigment, which is going to be your red mercury cinnabar containing tattoo pigment within the sarcoidal granuloma. So this is the most immunogenic, the mercury or the cinnabar containing tattoo pigment within the sarcoidal granuloma. So that's sarcoidal granulomatous dermatitis from, the red tattoo pigment. Okay. Now next come to more depositions. We talked about this last time when we were doing your slides, and that's calcium deposition. So calcium deposition, as we talked about, will occur in three forms. You will have idiopathic calcinosis cutis, you will have subepidermal or subepithelial calcified nodule, and scrotal calcinosis. So idiopathic calcinosis cutis, which is the most common, it is idiopathic. It occurs from a previously ruptured cyst, acne, or follicle, and it's not infrequently. You can also see it in existence with other tumors like BCCs or desmoplastic trichoepes or MAC, and you just see calcium deposition. So that's your calcinosis, idiopathic calcinosis cutis. If you see this in the background of smooth muscle bundles, that is indicative of scrotal calcinosis. So you can see here the nice smooth muscle bundles. So that's a Darter smooth muscle bundle, and its background, you are seeing this nice, dense, purple, chalky material, which is your scrotal calcinosis. So that's scrotal calcinosis. Another distinctive variant is going to be your subepidermal or subepithelial calcified nodule. And that we talked about last time. This appears as a wart-like chalky lesion on the face of a kid. And what you see is verrucous epithelial hyperplasia, and juxtaposed right beneath it is going to be this nice calcium material. So you can see this calcium deposits beneath a juxtafied, beneath a hyperplastic verrucous epidermis. So that's subepithelial or subepidermal calcified nodule. So those are the different kinds of calcium depositions that they like to show you. The next one, we did talk about this last time as well, is osteoma cutis. So osteoma cutis is the presence of lamellar bone. So it will always occur in the background of calcification. So you can see some degree of calcification which has formed this bone. But what makes it bone is the presence of a central collagenous vascular core, which will sometimes even have fat within it. But most importantly, you can see the presence of lacunar cells, these empty spaces which contain the osteocytes. So when you see this, you know that it has formed lamellar bone. So the most common cause of osteoma cutis is again idiopathic, from a calcified cyst, or most commonly like you can see that within the calcifying epithelium of Malherbe, which is your, pilomatricoma, or a previously ruptured follicle, or an acne scar. But, it could be indicative of even diseases like CREST or scleroderma, and fibrodysplasia ossificans progressiva, and McCune-Albright hereditary osteodystrophy. So, you should know the secondary conditions associated with osteoma cutis. One specific kind of osteoma cutis, which occurs in one specific location and can be asked, is subungual exostosis, which is also referred to as a osteochondroma. So in subungual exostosis, this is formed as a result of trauma. So it's near the nail bed region, or it could be beneath the nail plate. So you will often see thick keratine layer, which could be a portion of a nail. And right beneath it, you will see fibrosis and granulation tissue. So you can see the fibrosis and granulation tissue and a cap of cartilage. So you can see the nice cartilaginous cap. And this cap is overlying the bone, which formed bone. So this is again lamellar bone, which has been formed as a result of chronic trauma in the region. So you can see again calcification and the bone formation with the lacunar spaces of osteocytes and the central fibrovascular core containing some degree of fat within it. So that is an example of subungual exostosis or an osteochondroma. So, this is a question that can be asked. Coming to your next deposition, again, extremely high yield. I think if you guys see it once, you will always remember it, and you guys have already probably seen it. This is ochronosis. So ochronosis, you get the golden brown swollen banana bodies, or which which is could be seen in both primary and secondary ochronosis will look similar. So primary ochronosis, which is the autosomal recessive disorder with um, deficiency of homogenesic acid oxidase, is going to produce this, and so also will secondary ochronosis, which most commonly occurs because of use of your the bleaching agents containing hydroquinone. So when you see secondary ochronosis, you often see solar elastosis in the background. It is not diffuse and extensive as primary ochronosis, but you do see these swollen banana bodies. So that is ochronosis. The next deposition, which is again iatrogenic, is going to be argyria. So argyria produces you a brownish, blackish material, but the way it is deposited in the tissue is the one that makes it this entity very distinctive. So you can see how this pigment, it wraps around the smooth muscle bundles. You can see them wrapping around, nicely deposited in a linear fashion along the dermal, interstitial, or collagen elastin fibers. You can see the nice deposition around the sweat glands. So the way it wraps around the dermal connective tissue is very classic for argyria. Otherwise, the pigment is pretty non-discrete. It probably has the same quality as amalgam tattoo or the other things that I'm going to show you, but the way it is deposited in the dermis is very classic. So that is argyria. The next one is going to be your amalgam tattoo. Amalgam tattoo most commonly occurs on mucosal sites. So, it's from a prior dental procedure. And what you see is again this kind of golden brownish pigment, which is going to be associated with the foreign body reaction, which is again deposited on the connective tissue. So you can see the nice deposition. They try to confuse this with a labial melanotic macule or with a blue nevus of the labial mucosa or melanoma. Clearly it isn't. You can see the nice deposition. The deposition can even occur along the dermoepidermal junction. You recognize it to be the mucosa. There is no granular cell layer. A labial melanotic macule is just a labial lentigo. So you will see basilar epidermal hyperpigmentation with obviously no exogenous pigment. You often see pigment drop out. You often see melanin pigment in the superficial stroma, but there is no melanocytic proliferation. So this is amalgam tattoo. Coming to your next, your drug-induced pigmentations. Most commonly, one asked is a minocycline pigmentation. You know that minocycline pigmentation is type 1, 2, and 3. Type 1 is the one which most commonly occurs in acne scars, and 1-for-1 pigment, and that is hemosiderin. So that stains with Pearl's iron. So the two pigments, the hemosiderin stains with Pearl's iron and melanin pigment stains with Fontana Massan. So the type 1 minocycline pigmentation typically occurs in the background of a scar. So you can see here scar tissue, and you have deposition of pigment which contains hemosiderin. And you can confirm it with using the Pearl's iron stain. So this is a Pearl's iron stain, and you can see how nicely it stains all the hemosiderin blue. So type 1 minocycline is for one pigment, which is hemosiderin, which is in the background of most often a scar. This is going to be in contrast to your type 2 minocycline pigmentation, which is deposition of two types of pigment. You have melanin pigment, which stays with Fontana Massan. So you can see it is much more darker black. That is melanin pigment. And the other pigment is going to be your hemosiderin pigment, which is going to be lighter. It is going to be more golden brown, which is deposited here. So this will have both the pigments. So both Pearl's iron and Fontana Massan will be positive. So that's type 2. So 2 for 2 pigments, both hemosiderin and the melanin pigment. The background of a type 2 minocycline pigmentation can often look like a dermatofibroma. So there is some dermal fibrosis, and you can think about a DF because of all that pigment. But obviously, it lacks the fibrohistiocytic spindle cell proliferation. That's your type 2 minocycline pigmentation. And type 3 is generalized muddy brown hyperpigmentation on sun-exposed sites. That is, again, only melanin pigmentation. Okay. The next one, I had alluded to this before, is an aluminium granuloma. So aluminium granuloma occurs in two scenarios. The more common one is it has a dry sol reaction which contains aluminium chloride. And the other one is from a vaccine reaction, which is aluminium hydroxide. So aluminium chloride is in dry sol, aluminium hydroxide is in your vaccine. But the kind of reaction it produces is similar. So you can again see these epithelioid histiocytic cells, something like what I showed you in a Monsell's granuloma, but you can see that the nature of the pigment is different. So in a Monsell's, it's golden, darkish, blackish brown material. Here it is going to be more amphiphilic, purplish material, which is filling up. It is also granular and it is filling up the histiocytes. So this is an aluminium granuloma. It can occur because of dry sol reaction, which is aluminium chloride, or vaccine, which contain aluminium hydroxide. The next exogenous pigment we are going to talk about is silver nitrate. This is not very common, but when you do see it, it has a very peculiar appearance. The pigment, which is again this darkish blackish brown pigment, is deposited just in the stratum corneum. So you don't see it anywhere else. So you can see the nice dense pigment in the stratum corneum. So that is silver nitrate. That's topical silver nitrate. The next one I'm going to talk about is your cavitin granuloma. So cavitin granuloma is going to produce your foreign body reaction with slit-like spaces which contain the cavitin fragments. So when you see slit-like spaces, the three things that come into your mind are a cavitin granuloma, cholesterol clefts, and a foreign body, which is your filler, which is your polyallactic acid or Sculptra. So let's distinguish between these three. So a cavitin granuloma, which is the most common one, will produce you a foreign body reaction where you have these slit-like spaces which contain the cavitin fragments. You also get the cavitin fragments in Sculptra, which is polyallactic acid filler, but that also contain a polarizable material. Okay, so slit-like spaces, cavitin. The background you can see is very mixed. Can have giant cells, lymphocytes, neutrophils, eosinophils, but the slit-like spaces contain pieces of cavitin. Often, if you look around, you will see a remnant of a ruptured cyst or a follicle, as you can see in over here. So that is your cavitin granuloma with the nice cavitin-containing flakes. Now, the cholesterol clefts, when you see it, it will obviously the background of the cholesterol cleft matters. So it doesn't have the cavitin flakes. It obviously has cholesterol, which, you don't really see it, but you just see the cleft-like spaces. But the background is all foamy xanthomatous histiocytes. So they're all lipid-containing histiocytic cells. Whereas in a cavitin granuloma, it's a very mixed infiltrate. So that can be used as a clue. I'm going to talk about polyallactic acid, so I'm going to come to that. But before that, I want to show you hair shafts. So hair shafts can also incite a foreign body response, right? For example, the term pseudofolliculitis is from ruptured hair shafts. It's not a true folliculitis. So this is how the hair shafts look like, pigmented with pigmented granules. And this is an example of a pilonidal cyst. So pilonidal cyst is a classic example. This is a very nice example of a pilonidal cyst where you see disrupted hair shafts and follicles which have produced this inflammatory foreign body response. So it's important to recognize the hair shafts. Now, remember, hair shafts can sometimes even look like a suture material. So be careful that you're recognizing hair shafts. And the hair shafts can also sometimes polarize. So, you should be careful with that. This is a nice example of a hair shaft which incited a beautiful foreign body reaction around it. So you can see this is a hair shaft with the granulomatous response around it. So recognition of a hair shaft is important. I'm not forgotten about the filler. I'm going to come to it, but let's talk about other materials. This is splinter. So splinter has a nice thick cellulose plant, these walls within it. Now, splinters are easy to recognize. It becomes a problem when they throw a splinter and a splinter with superimposed dematiaceous fungus. Every time you see a splinter, you can always convince yourself that, oh yeah, there is some fungus within it. But this is not fungus. This is a part and parcel of the splinter. So make sure that you know that. When you see a superimposed dematiaceous fungus of pheohyphomycosis, we'll again talk about this tomorrow when we are discussing infections, is you're going to see the fungus will look very obvious. So you can see this is a splinter and you can see the fungus growing on top of it. This is a pigmented fungus and hence it is dematiaceous fungus of pheohyphomycosis. So it looks really obvious. So every time you see a splinter, don't think there is a fungus going along with it. So this is not uncommon. You will see the fungus along with the splinter. That's how they get in the body. The next one, foreign material, is going to be a suture granuloma. So suture granulomas can again look in different kinds. This is probably the more common ones wherein you get the nice foreign body reaction. So you can see the nice foreign body giant cell reaction to pieces of this suture, which have this kind of bluish grayish look to it with the foreign body response surrounding it. So that's a nice suture granuloma. It doesn't always look like that. It can look different kinds depending upon the kind of the suture material. This looks like a more refractile foreign body. That's also suture. This is again another example of a suture. This is probably the most difficult one to recognize because it produces translucent structures. So these will be polarizable. They often produce these kind of like empty slits and spaces in the tissue with foreign body response. And you have to like go and look for this kind of translucent material within that space. That's suture. Spitting suture is also not uncommon. So in spitting suture, there is a cystic invagination from the epidermis, which is trying to get rid of the suture material. So you can see the nice suture material within the extruded stuff. So that is your spitting suture. The next exogenous foreign material we're going to talk about is steroid injection, which is your Kinalog. So you can see that steroids or triamcinolone are most commonly seen in the background of a keloid or a hypertrophic scar, though that's not the only time you're injecting these lesions, but because these get excised, we often get to see the steroid, and that is triamcinolone. So you can see this nice foamy, vacuolated material, which is pink, frothy looking. It doesn't incite a foreign body response. It's very quiescently present in the dermis. So you can see the nice triamcinolone. So this is an important board question, recognition of Kinalog. The next one is going to be gel foam. So gel foam is most often seen in the recent procedure, and you often see an ulcer bed or with reactive pseudoepitheliomatous hyperplasia. So this is all just reaction. This is not a malignancy. And you can see within the ulcer bed is this very foreign material, which obviously looks like a foreign material. It often has this kind of polygonal dark blue morphology. So that's gel foam. Show you another example. This is from a very, very recent procedure. So you can see the ulceration with the serum and the crust, and you can see this material, which is all gel foam. Okay, so now let's talk about your fillers. So the most common filler that we encounter is hyaluronic acid, which is seen in Restylane and Juvederm. So hyaluronic acid is basically like exogenous mucin. So this typically is most least inflammatory. So you do not get much of inflammatory response. Forms more like a mass forming lesion. So you can see here this dense bluish material, which looks very much like mucin, which is present in the tissue. But it is not very immunogenic. It doesn't incite a whole lot of response. So that is all your hyaluronic acid, which is seen in Restylane and Juvederm.
Do you think the site helps as well? Like, is that
The site
the site of
helps.
lips as well with the muscle?
Yeah, but see, you can see here, this is the smooth muscle bundles, right? There's some actually skeletal muscle bundles. So this is near the lip region. It's gone enough. Sometimes it comes off just in lip pieces. But lips are a common site of not only Restylane, there's sites of other fillers as well. So like I have a slide of polymethyl methacrylate, which is on the lip. So it's the quality, I think, which you basically want to recognize. It's easy. Once you're thinking about it, you will recognize it. The next one is the polyl-lactic acid. This is the one which probably is the most challenging one. So this was actually, it came to me as a second opinion because this was called a ruptured cyst. And you can see why, because you see all these slit-like spaces with the surrounding foreign body reaction. So it really looks like a keratin granuloma with all these slit-like spaces and this They will even have pieces of keratin within them. But in the background, if you notice, there is a material. So you can see this material. That's your filler. So you see this empty translucent material. This will easily polarize under the microscope. But for you guys, you will have to recognize it. So you can see that material in here. Does everybody see that? It's like this empty translucent material. There will be some keratin flakes as well, but it is this material that you're looking at. So that's polyalactic acid, which is what you see in Sculptra or Neufil. Okay. Let me see if I can. I really need to pull up my PowerPoint now, but I don't know why it is not letting me in. Okay. I'm going to go out of my thing if I basically do that. I'll tomorrow morning remind me the first thing I'm going to show you the slide. It's like a small PowerPoint of the fillers. It's pretty much what I'm showing you, but there is, I think, a couple which I will not be able to show you because I can't pull up my PowerPoint. So that is your polylactic acid, Sculptra or Neufil. The next one, which is they like to ask you, is the polymethyl methacrylic acid. That is like Articol or Metacryl. It produces, you see, this is the lip again. You see the mucosal side. It produces this very uniformly placed microsphere. So they look very monotonous. So almost every small round space looks similar. The material within it can be a little mucin like what you see in here, or you could even have like calcium within it. So like something that looks like calcinosis cutis. But you recognize polymethyl methacrylic acid by the uniformity of the microspheres. Okay. Uh, the PowerPoint that I wanted to show you has Radix. So Radix is calcium. So if you see proper calcium with the foreign body reaction and the filler that they are asking you, that is Radix. Okay. So hyaluronic acid is the mucinous substance. Polyalactic acid Sculptra or Neufil is something that looks like a keratin granuloma, but it has that refractile material. If you have very uniformly placed microspheres like this, that's polymethyl methacrylic acid. And if you have distinct pieces of calcium, that is Radix. Those are the most common kind of fillers that they like to ask. Other than that, we have talked about silicone granuloma, which has a Swiss cheese appearance. So it has these variably sized cystic spaces, which look like fat, but they are markedly variable in size and morphology and have an associated foreign body reaction with it. So variably sized spaces with the foreign body reaction, looking like a Swiss cheese. So that's a Swiss cheese granuloma. I think you guys are pretty good at silicone granuloma. You're good at recognizing it. The more challenging one that you encounter is your silicone granuloma or a paraphenoma. So a silicone granuloma or paraphenoma is produced by a hydrophobic foreign material. So what it produces is these kind of like empty spaces in the dermis. They're very tiny empty spaces. They almost look like water droplets in the dermis. This similar kind of a reaction, if you remember, can also be produced by lepromatous leprosy. So lepromatous leprosy also produces these empty looking histiocytic cells in a diffuse pattern in the dermis with minimal other inflammation. However, in lepromatous leprosy, the key is to recognize the bacteria, which are your globoid cells, which are those fluffy organisms. And again, we will talk about this tomorrow. So tomorrow, I'm going to show you a slide of lepromatous leprosy. It can look very similar. So they have these tiny empty cells, which are all histiocytes, which are stuffed up with those bacteria. That's the closest differential for a sclerosing lipogranuloma or a paraphenoma. The marked variability in the size of these droplets are some small. This is what makes you think that this is exogenous. Okay, and it can have some degree of foreign body response with it, like giant cells and granulomas, though that is typically not as exuberant as you see in other foreign body responses. So you really have to rely on recognizing with these tiny like water droplets within the biopsy. So that is your paraphenoma or sclerosing lipogranuloma. And I will show you the lepromatous leprosy tomorrow, and I'll show you how similar that can look. So that is the end of these iatrogenic substances. So tomorrow we are going to do infections. I know we have a few study sets to go through. I think we went through the deposition and metabolic, right? So this is the other one. This is the alteration of we did the chapter 14 last time. Is that correct?
Yes.
Yeah.
Okay. I do have to end in 10-15 minutes, but we can start with this if you guys want to do it, and we'll see how much we can get done. So what do you think about this first one? This is all revision. We've all done this.
Lichen sclerosus.
Yes, it's pretty classic for lichen sclerosis. You see the epidermal atrophy, the homogenized dermis, and a band of inflammation that has been pushed down. The closest differential for this would be radiation dermatitis, in which you will get variably sized vessels. Okay, that's the number 2.
Where they have a sclerotic collagen with loss of space between it and trapping some of the adnexal structures, so morphia.
Yep. So you can see the nice entrapped adnexal units with the lymphoplasmacytic infiltrate. There is loss of space between the collagen bundles. So good job. So this is morphia, and scleroderma will also look same. Everybody can shout out. What is this?
Ochronosis.
Great job.
Is this radiation dermatitis?
This is radiation derm. So you see how the dermis looks kind of like homogenized, but it's not perfectly located. The epidermis, as I said, can always be very variable, but you have all these very variably sized ectatic vessels with abnormal lumens. And so that is your radiation dermatitis. Good. Everybody got that? Okay. Okay. Again, a low power diagnosis. What is this?
Lichen sclerosis.
Again, see the nice 3 zones at hyperkeratosis, homogenized, band of infiltrate, push down. Slide 6. 6 I haven't taught you guys, but you guys know what it is. What is it?
PXE.
This is pseudoxanthoma elasticum. I think, or maybe I did teach you guys. PXE, this is a destroyed coiled elastin fibers. They often can have dystrophic calcification on top of it. So look for that for calcium. So this is PXE. Remember, D-penicillamine therapy can also do that. Plenty of second order questions to be asked with the PXE. So it's a very high board yield. Next one is 7. Okay. So what do you think? Come on, you guys know this. What is that?
Morphia.
Yes, so this is dermal thickening with loss of space between the collagen bundles. So this is not scleroderma. I'm sorry, this is not sclerodema, but this is morphia or scleroderma. Actually, this is from a patient with chronic sclerodermoid GVHD. So you cannot distinguish between scleroderma morphea and sclerodermoid GVHD just based on the biopsy. However, it does have a clue. And the clue is it's probably not going to be visible to your eyes, but the overlying epidermis is a little, it has a touch of vacuolar alteration. That can sometimes be a clue. There is even some pigment dropout in there. And pigment dropout does not happen in classic morphea or scleroderma because there is no reason, right? They do not involve the epi. But in chronic sclerodermoid GVHD, that will happen. So this is sclerodermoid GVHD, but it is indistinguishable from morphea or scleroderma. Good. Next one is slide 8. Okay, we've talked about this. There's a diagnosis here.
Perforating disorder.
Which one?
Is it collagen that it's perforating?
So this is Curley's disease. So the collagen one is reactive perforating collagenoses, which I can guarantee you they're not going to ask you that. That's the least common. It looks like a giant ulcer. It actually looks indistinguishable from the ulcer. That's the only kind of like the one that looks very different from all the other perforating dermatosis. So this is Curley's because it is more endophytic. So you can see it, the ball and the claw surrounding the keratin, and then boom, it is extruded out. It's not folliculocentric. It's not around the hair follicle. So this is Curley's disease, but it is very classic for a perforating dermatosis. This is what you recognize in a perforating dermatosis, is a perforation. And the perforation is produced by this claw-like cystic invagination into the skin. Good. Okay. So this one I put in there because I haven't taught you this, but this is an important board question. When you see a number of these cystically dilated spaces, these can either be milia or these can be comedones. So based upon what they're asking you, this could be milia and plaque. For I cannot pronounce that syndrome, you know, the syndrome that I'm talking about. Or it could also be something like comedonicus, though your comedonicus nevus. So based upon what they're asking you. But this is pretty good for milia and plaque and that syndrome. Okay. This is slide 10. What's happening in here? Yes, I'm yawning. You don't want to know what time I was up till last night.
It looks like morphea, but it's really deep. And maybe like
Great.
starting
So
a septal paniculatus.
Yeah.
As part of it.
Yep, beautiful. So this is deep morphea or morphea profunda. This is the kind which is very likely to be associated with an underlying eosinophilic fasciitis. Okay, so that can be asked. So you can see here, this is normal. You can see here, this dermal collagen is absolutely normal. The process is actually beginning in the deep dermis, almost in the fat. And you can see how it has produced a septal fibrosis and thickening and how easy it is to confuse with enodosum because it produces the widened septa. But this is, it can be very challenging sometimes to distinguish between chronic enodosum or deep morphea profunda, especially when the entire process just begins in the fat. So this is deep morphea. Good. Okay, did you guys recognize this? What is this? I put in this for a reason. So the dermis is thick, right? When you go up on dermal thickening, what do you see? There is collagen deposition, but you also see what? Fibroblastic proliferation, right? And you see the effacement of the reedy ridge pattern above it. This is a scar or a hypertrophic scar. So hypertrophic scar also produce dermal thickening, but they have accompanying random fibroblastic proliferation with effacement of the reedy ridge pattern above it. You can see how uh, there are prominent vessels superficially. So scar is also a fibrotic and a sclerotic process, right? But it differs from your morphia and scleroderma because it produces fibroblastic proliferation. But unlike a scleromyxedema, which also has fibroblastic proliferation, this typically will not have mucin, or actually mucin can be non-subjective, so let's not talk about that. But this is more like an organized lesion. It produces much disruption of the epidermis, much more random fibroblastic proliferation, thickening, and effacement of the epidermis overlying it, the reedy ridge pattern of the epidermis overlying it. So this is hypertrophic scar. The next one is your 12. If that was hypertrophic scar, this is,
Keloid.
yep. So this is keloid, but this is not acne keloidalis nuchae. Acne keloidalis nuchae is a misnomer. It doesn't have any keloid within it. So this is just a plain keloid. You see the densely hyalinized collagen bundles. The next one is 13. What is this?
Rheumatoid nodule.
Mm-hmm. So I put it there just to throw you guys off because you can again see it has a very nice palisaded background. But again, it's important to go inside it and recognize it because on low power, it could also be gout. So when you go up on high power, this is clearly fibrinoid necrosis. So this is a deep-seated rheumatoid nodule. Good. 14th. Okay. So low power, what does it look like? What does this remind you of, this dermis?
Lichen sclerosis.
Yep. But is it lichen sclerosis?
No, it's radiation dermatitis.
Mm-hmm. The epidermis is very variably hyperplastic, and you can see all these abnormal vessels. You can see varying in size and shape with some even intraluminal hemorrhage and thrombosis. So that is radiation derm. Good. The next one is 15th. So what is this?
Morphia.
Yeah. So this is again beautiful morphia. You can see the densely sclerotic dermis with obliteration of space between the collagen numbles. You can see the trapment of the sweat gland and an lymphoplasmacytic interface as its junction with the dermis and subcutaneous. So that is morphia or scleroderma. What is this? What is that?
GA.
It's NLD. It's late stage. So you can see how it also produces you the squared off biopsy. With this, if you look in the center, this is the same sclerotic collagen, what you see in morphia, but you see that there is outline of, that's why you recognize it to be GA, because you saw the palisaded granulomas, but they're in the form of a layers of a cake involving the breadth and the depth of the dermis. So this is NLD on its kind of like way out. The reason I put in there is because the quality of the sclerotic collagen can look very much like morphia. So as the lesion of NLD grows old and the granulomatous inflammation subsides, it will actually tend to look more like morphia. But then morphia does not have granulomas. Okay. The next one is 17. I made it easy for you because I keep on dotting the stuff, which I shouldn't have. But does everybody recognize this to be what? Fill in the blank.
EPS.
It's a perforating disease. First of all, everybody wants, you cannot straight away get at EPS. The only thing you can tell on low power is it is what? Perforation, right? You can see the nice perforation, a cystic invagination where some stuff is being extruded out. When you go up on high power, so this is not really endophytic. It's not centered around a follicle. So it's not Curly's, it's not perforating folliculitis. But do you see this? These are the extruded elastin fibers. So that is EPS. Good. The next one is 18th. This is
PXE.
good. This is again
LSNA.
good. So we learn by repetition. 20th. What is that? Another rheumatoid nodule? It is a rheumatoid nodule. I thought it was gout, but it is another rheumatoid nodule. It's not gout. I was kidding with you guys, but it is a rheumatoid nodule. So you can see here the nice palisaded nature, but it could very well have been gout. That's why it is so important to go up on high power and to look at what the substance is in the center. It's a nice location as well. You can see the acral skin. The next one is 21. That is?
Morphia.
So you see, this is the part abnormal, which is this is normal, this is abnormal. Good. The next one is, this is
Lichen sclerosis.
good. Ah, man, I need to stop doing that. Has everybody recognized this to be what? Perforating. So now you see this is centered around a hair follicle. And the reason I know is because these are hair shafts. These are like the remnants of a hair shaft. So this is perforating folliculitis. So we saw Curly's, we saw perforating folliculitis, we saw EPS. But you see the similarity between all the perforating dermatosis, they all look similar with that perforation and extruded material. This is
Radiation dermatitis.
perfect. Next one. This is
Morphia plus lichen sclerosis overlap.
yeah, morphia, LSNA. Morphia with overlying LSNA. Good. 26. Where do you think I am? I am. Do you see any skin? This is the fat. So what will be beneath the fat? What are all these?
Eosinophilic fasciitis.
So this is eosinophil. So there's nothing spectacular about the biopsy. You just need to get the fascia and we need to see eos in it. Good. Okay, so tell me what is happening in this slide. Something is very obvious, right? What is all this?
Calcium.
Calcium. But the second order question that they will like to ask you is this idiopathic calcium or there is some problem in the dermis behind? Is this normal architecture of dermal collagen?
No.
What is abnormal with it?
Thickened.
Again, there is loss of space between the collagen bundles with tons of calcium deposition. So what disease will have calcium deposition with dermal sclerosis?
Like crest.
CREST or scleroderma. So this is actually from a patient with CREST who had bad renal involvement as well. Yep. So this is important. So this is a cause of a secondary calcinosis cutis associated with CREST/scleroderma. Good. This is again an example of this, I think, came in with us with this. So this slide, if I was to show you, what slide was it? 28th?
Yeah.
So let me see what the 29th is. Okay, first let's do the 29. What is 29? It's so beautiful. What is it? No?
Like scleroderma.
Yeah, it's in that category. But you see how beautiful this morphia has now gone even down the, you
Yeah.
see the nice, this is called the swollen face sign. So this is morphia, but it is also associated with deep morphia or morphia profunda. So that's really nice. Notice another thing that I had told you. You look at the epidermis, you see all the pigment dropout and the hint of vacuole alteration. So this is again in a patient with chronic sclerodermoid GVHD. Look how identical it looks to morphia scleroderma. And that is your clue, the pigment dropout and subtle vacuolar alteration. Okay, now let's come back to this. So describe to me what you guys are seeing over here. It's easy to describe. Is the dermis thick? Yes, the dermis is thick. Is there loss of space between the collagen bundles? Yes. Is there loss of adnexal units? Yes. Is this a scar? I'm looking at that screen because I'm seeing you all guys. Somebody is nodding, somebody is not nodding. So is this a scar? Okay. Kristen, you said no. You nodded your head no, which is the American no because Indians do this. Oh, no. Okay, so you tell me, why don't you think it's a scar?
The epi didn't look a face to me.
Good. And how about Shireen? Give me another reason why you don't think it's a scar.
It just doesn't
Vessels
look
aren't
random
perpendicular.
enough. Yeah.
What is it?
The collagen bundles, they're not perpendicular, not like random enough.
No, so it's because this doesn't have fibroblastic proliferation.
Oh, that's another one.
You see that? So those things are typically seen in a scar. Okay, so could this be morphia? Everybody's agreeing it could be morphia, right? But if I was to give you a second order question with this, and if I was to tell you this is a patient, blah, 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 has this plaque and whatever, and then I basically tell you that the for further evaluation, trichrome and a VVG stain were done and show some characteristic findings. Do you know what disease I'm referring to? What happens to the trichrome? What does trichrome stain do? What does it highlight? John, what does trichrome highlight? Collagen. So to analyze the connective tissue inside, what is collagen, what is elastin, we do a trichrome stain, which will highlight collagen, and we will do a VVG stain, which will highlight the elastin. Okay, so what do you think in morphia or xeroderma, what happens to the trichrome and the collagen VVG stain? Would they be disrupted? Would it be normal? Would it be increased? Would it be decreased? What will happen? They're unaffected. So if you were to take patients of morphia and scleroderma and you do a VVG and a trichrome stain, it's the normal collagen elastin. Nothing happens with them. If the collagen and the elastin are being disrupted, you are in diseases called connective tissue nevi, which are your collagenomas and elastomas. Do you get it? So disruption of collagen and elastin is what you are seeing in diseases like perforating dermatosis, which is reactive perforating collagenosis, or your EPS. You're seeing it in pseudoxanthoma elasticum. You're seeing it in cutis laxa. You're seeing it in mid-dermal elastolysis, anetoderma, all those fancy names. Those are the ones which are producing you destruction of collagen and elastin. The diseases that I just mentioned are all producing you destruction of collagen and elastin. So technically, all of them can either look like normal skin or they can produce some degree of dermal thickening, which may look like morphia. Okay? They're collagenomas and elastomas, which are connective tissue nevi. So when I call something a connective tissue nevus, I'm referring to a collagenoma or an elastoma. Okay? A collagenoma and an elastoma will both look like this. To determine which one it is, I will do a VVG and a trichrome stain. So if the VVG stain shows complete loss of elastin with just trichrome collagen, it's a collagenoma. If it's the opposite, if it just shows elastin and there's no collagen, it's an elastoma. Okay, so this is actually a collagenoma. And so can you even imagine how many second order questions I can make from this slide? Collagenomas are seen in what condition? They can be isolated. You could see them eruptive collagenomas. You can see them in Sjogren patch of tuberous sclerosis. The Sjogren patch of tuberous sclerosis is a collagenoma. I think you also see it in Proteus syndrome. So many other syndromes they can ask you. Elastoma, beautiful second order questions. Your osteopoikilosis and what is that? Dermatofibrosis, that something lenticularis or something, perstans, all those. So they can ask you a lot of questions. So the bottom line is this is how a collagenoma elastoma looks like. They look like an old lesion of morphia or an old scar, but the pattern of collagen and elastin will be disrupted. The collagen elastin is also disrupted in a scar, but we never do the collagen elastin in a scar because you can obviously recognize it. Does everybody understand the context of this slide? Okay. Then we have the 29th. Oh, we did that. The slide 30 is a classic example of acne keloidalis. So you don't see any keloid in there, but you see free-floating hair shafts with a lot of inflammation and dense tissue, which looks like scar. So you can see this lymphoplasmacytic inflammation. There is some old blood and hemorrhage. And then you should see like free-floating hair shafts within the lesion, which is what you see here. So this is acne keloidalis. And then I think that was the last slide. No, there is a 31, there's a 33. Okay, so You guys know this. What is this? This is morphia. I think everybody can recognize that. Then we have a 32. This is again morphia. You see, this is the process which is involved. This is normal. This is abnormal. And we have the 33. Oh, which I highlighted it here. What am I showing in here? Okay, this is a very, very nice example of chondrodermatitis. So in chondrodermatitis, the dermis kind of looks like homogenized. But you have this background solar elastosis, this telangiectasia, some granulation tissue formation, and the overlying epidermis is unevenly hyperplastic. So this on low power, even without the cartilage, you should be able to recognize, but it also has a little bit of cartilage. You see that at the bottom of the lesion. This is chondrodermatitis. Okay, so I will see you guys for you all, I will see you guys at 12 tomorrow.
Would you be able to go back
Okay.
to 31 real quick?
What is that?
Would you be able to go back to 31 real quick?
Oh, okay. Where is 31 here?
Is this more like infiltrate that you would see typically for scleroderma?
Say that again?
I just thought there was a lot of lymphocytic infiltrate in this one compared to the other past slides we saw for like morphia.
So this is probably, you cannot distinguish it based on the lymphocytic infiltrate. So there can be both. So this is in a very active inflammatory stage of morphia. There's another unusual finding in this. This patient has superimposed contact derm. Do you see that?
Yeah, I think that's kind of what threw me off, maybe.
Yeah, so this is but based upon the lymphocytic infiltrate, you cannot distinguish between morphia and scleroderma. Actually, honestly, you cannot distinguish between the two. The only time where you can is if it has like the calcification that may give you a hint, but even that is not like pathognomic. That was from a patient with CREST syndrome, and that's the reason I could make the diagnosis, but otherwise not. Okay?